Welcome everybody, good afternoon, and welcome to the first lecture in the series on health and healthcare, organized by a group of fellows from Max Weber program at the European University Institute. I'm Tamara Popic, I'm one of the Max Weber fellows. I will be moderating today's session, and I have an honor to introduce to you Professor Terje Andreas Eikemo from the CHAIN, Center for Global Health Inequalities Research. And thank you very much, Professor Eikemo, for accepting this invitation and to take part in this event. So today, just to tell you shortly about the structure of today's session, there will be around 30 minutes of Professor Eikemo's talk, and then we will have a Q&A, which is meant to be interactive, and therefore we also wanted to ask participants to keep their cameras on, or at least when you're asking a question, please turn on your camera. So as I said about Professor Eikemo, he's the leader of CHAIN, Center for Global Health Inequalities Research, and also a professor at the Department of Sociology and Political Science at the Norwegian University of Science and Technology. The focus of Professor Eikemo's work are differences in mental and physical health, in chronic diseases and mortality within and across countries in different regions around the world. And the aim of CHAIN, Center for Global Health Inequalities Research, is exactly to monitor, explain and reduce health inequalities around the world. And to achieve this aim, CHAIN has worked with partners in academia, but also in policy. Just to mention some organizations, UNICEF, for example, also UNICEF Innocenti. Professor Eikemo has collaborated closely with them, and they're also located here in Florence. And also, for example, International Agency for Research for Cancer by the World Health Organization. Professor Eikemo has led various projects on the topics of public health, and was awarded different scientific prizes, just to mention a prize by the Royal Norwegian Society of Science and Letters, and also the Sintef Prize for Outstanding Research. Today, Professor Eikemo will talk about health inequalities, of course, but focusing more closely on the role of the health system. So without any further ado, I give the floor to Professor Eikemo, and I'm looking forward to the talk and to the discussion afterwards.
Thank you so much, Tamara, for this really thorough introduction. Yeah, you seem to have been studying my profile quite a lot, so that's good to be reminded of all this work that we've been doing. And it's just so great to be invited, not least because I know quite a few faces here. Some of you I haven't seen in decades. I can see Erasmus here. I wonder if you're stuck in traffic, but I hope that you can get my lecture where you are. It's been a long time since we were together, and I'm going to present some of the research we did together. So you can look forward to that. At least one slide, and I'll try to remember to mention to the whole group here that this is something we did together. Yeah, it's great to be here. What you did not mention, Tamara, is that I'm also the editor-in-chief of the Scandinavian Journal of Public Health. And sometimes what happens is in a group like this, there will be people whose papers I have rejected in the past. So I hope that there are no evil intentions here. Other than that, I would strongly encourage you to send your papers our way, of course. Okay, so for the topic for today, I will have a PowerPoint slide that I will share with you. I will speak for about half an hour about a topic which is very close to me, or close to my heart, I'd say, because it's going to be about inequities, health inequalities. I will start very broadly, globally. I also see here that the audience is global. So although most of you perhaps are concerned with European countries and European perspective, I will start more broader before I tune in on the European situation. And I will also talk more specifically on the significance of health systems in understanding the variation of health inequalities, although that will not be the topic all along. But I will tune into the significance of health systems eventually, although I would expect that most of you are or all of you would be more an expert within that field than I am. I think my approach is more general, we think that studying health inequality is important at all levels, from the genetic level to the to global forces. It's basically an empirical question, and not a question which is restricted to a certain discipline. I will also talk about CHAIN, which is the center you have introduced, that I'm directing from here from Norway, and our perspectives and methods of working, and of course I will then in the end, towards the end, talk about health systems and how we can perhaps as precisely as possible measure their performance in terms of producing or reducing inequalities and social inequalities in health. So I'll find my presentation and see if I can share my screen. There. Hope you can see this. And please do visit our Facebook, Twitter homepage if you like. And of course, this presentation will be available hopefully even after the live presentation, so you can go back to the slides and find the links. So as I told you, I will start more broadly, and usually when I present a research, I'm presenting a statement concerning the resources a child is born with, and when a child is born, it's given, I think, two main resources. It's health, or the lack of health, and the education of its parents. So health and education are two kind of key components of the research I'll be conducting. And as I will show you, these two resources are related to each other. So good health is important for children. And that is not only because it will help them live through their first years, but also because it will help them fulfill their potentials throughout their lives, including taking higher education. So already I'm stepping into the discussion of causality and selection. But it's also important for countries to have highly educated populations, and thereby also healthy populations in their efforts to obtain sustainable societies. And also because it will make them more robust in the fight against COVID. And I expect that the COVID situation might come up a few times, and perhaps also during our discussions. So health and education are important resources for children, for people, and for countries. And all people have the same right to education and health, but of course it matters where you live. It matters which health system you're born into. So if you're born in a poor country with a poorly developed health system, you're less likely to obtain your educational dreams, and you're more likely to live in poor health and die earlier of preventable diseases than if you're born in a wealthy country with more developed health systems. But the fact is that there is no country in the world that has been able to protect their populations from the negative health consequences of educational poverty. Now, these bars are collected from the DHS survey. Some of you might have used the survey already. Now, these bars, they present child mortality in rural regions from 1985 to 2000. So this is basically more than 20 years ago. And they show that children born by mothers with high education live longer than those born by less educated mothers. And this means that education, of course, matters. It means that the roots of health inequalities are placed in the social environments where children are born, where they grow and live, and eventually where they work and age, to cite some moment. So more education means, of course, better access to vaccination, clean water, sanitation, nutrition, housing, healthcare, transport, networks, health literacy, money, and I could go on. And all of which are protective mechanisms against illness and preventable mortality. So unequal access to these resources by level of education is key to explain the global health gap. Of course, what you also can see here is the social gradient, and the pattern is consistent across rural regions. So, and these numbers are, of course, well, quite a few years old. So let's have a look at the more recent picture. this would be the same numbers from 2001 till 2017. So basically almost 20 years later. And what we can see here is that child mortality has been cut in half. So the bars are lower. As you may know, child mortality has been reduced by half. It has been cut by half in relatively short periods of time, although the millennium goal was to reduce child mortality by 2/3. And our argument is that further improvement is hindered because children born by less educated mothers still have higher mortality. So the pattern is still the same. So we need to break the pattern in order to get further ahead. And the presence of such inequalities is among the biggest public health challenges in the world because it leads to large variations of child mortality. Now, I wanted to show this picture. These are 4 example countries from the same survey, showing that it is not always a matter of a social gradient. Sometimes we have educational gaps. And this has, of course, important implications for interventions. So if you want to reduce the health gap, sometimes we need to focus on the most vulnerable groups, while other times it might make more sense to think more structurally across the society. So in these countries, we can see that the main gap is between those with mothers with no education and mothers who have some sort of education. And what you can see here is the distribution of education to the left in the world. And to the right, you can see the distribution of mortality. And it might seem that they are related, but the fact is that we don't really know. We don't really know if there is a causal link between education and mortality. But it might appear that definitely the correlation is extremely strong. And the reason why I also show you this figure, it's collected from the Global Burden of Disease database, is because we are working very closely with the Global Burden of Disease study, which is, I think, the largest collaboration in science. It consists of thousands of researchers who are together trying to estimate the disease burden in the world. And I think that at the moment they are estimating the disease burden of about 85 risk factors on 350 health outcomes for 11 age groups, men and women, in more than 200 countries and regions. And of course, this is a massive effort. But still, they are lacking social variables. They don't have education or income or wealth or other social and economic factors. And that is something that we are trying to change in collaboration with the Global Burden of Disease Study. So that is, I think, in a few years from now, maybe in a couple of years, we will be able to estimate the meaning of education on mortality as compared also with the relevance of all other risk factors that the Global Burden of Disease Study has assessed. And the work has progressed. So this is a study that we are publishing in about 2 weeks. I'm not even sure if I'm allowed to show this, but I'm taking my chances because I think this is tremendously important. It is going to be published in the Lancet just before the G7 meeting in the UK I think it's June 7. And hopefully these findings can inform some of the decisions that are being made at that meeting. So what we have done here is that we have been trying to collect all the information possible from literature, from raw data, and to really establish the relationship quantitatively between parental education and child mortality. So we have been looking for literature sources exclusively. That will be the countries you see here in blue colors. So these are the countries for which we have actually found evidence of an association. And the countries that are more in yellow would be the countries for which we could only find data, but no literature studies of high enough quality. And the more pink reddish countries are the countries where we can find both sources of information. So we made a huge meta-analysis of this. It took us 2 years and 20 researchers, but we could eventually show that I think the findings are quite spectacular. This is a summary of them, that indeed there is a link between parental education and the child mortality, both at the neonatal age, post-neonatal infancy and childhood. This would basically mean neonatal would be like the first month, then the first year, then the first 5 years. So there's a social gradient, and the significance of father's education is also important. I think that is very often neglected in the literature, that father's education is indeed important. Another very important finding is that the effect is linear. So each year of education matters. It's not like with income, we see that the first euros or kroners or dollars you make would be more important, but for education, there is no threshold. And we can also find no differences between rural regions. So education matters to the same extent everywhere to explain the association between education, mother and father's education, and child mortality. So there's no difference between Scandinavia and Africa, basically, and that's very surprising. Of course, the child mortality is much larger in other regions than in Scandinavia or in Europe, but we have child mortality as well, and the degree to which we have that would be explained by parental education to the same degree. And this is the figure that I wanted to warn you about, where Rasmus and I have been collaborating. I think these numbers must be now, yeah, this is from the EuroGBD project 10 years ago. It says Eikemo and Mackenbach, but I think definitely it should be et al. So Rasmus is definitely there as well. So what we have seen so far in my presentation is that health inequalities, they start to emerge early in life, and also that it is a global problem. Now, those are the two main takeaways from my initial graphs. Now, this graph adds in two ways. It shows that health inequalities do not disappear through the life course, because these numbers are among the adult population, ages 30 till 74. The ages are not actually included in the graph, so you can't see that, but you have to believe me, these are adults. These are also men. And also the other takeaway message here is that health inequalities are not restricted to countries in the global south. It is the case that they are also present in European countries with well-developed health systems. And as I will show you later, there are indeed differences between European health systems. I mean, we can classify them in different ways. And as you see here, there are variations in the magnitude of health inequalities between European countries. Now, the question that I will answer later is, will we also see variation between health systems in the magnitude of inequalities? So if we start to cluster these countries into different health systems, will there be variations? And of course, the same picture emerges here as everywhere else. We see the gradient. The lower educated are the worst off, and also that there are important variations between countries, which are more or less disfavoring countries in the Central Eastern Europe. So I would now like to go on to present the way that Jane is trying to deal with these differences. So the fact that inequality kills such a large scale made us take upon a global responsibility to monitor the extent of health inequalities in the world through data capacity building and visualization of data. We are also attempting to explain these inequalities based on the data we are collecting, and not only explaining but also reducing inequalities through interventions and through the identifications of programs and interventions that can potentially reduce health inequality. So this is I would say, an actionable approach to research that is not perhaps so common. That a mission is to change something through research and not just doing the research for the sake of the research itself. And no country or region is going to be overlooked overlooked in these attempts. And the study that you could just see the results from the Common Lancet publication is just the first step. We're also going to look at adult mortality. We are going to look at cause-specific mortality. We're going to look at other social determinants. And in the end, the information we are collecting through these single studies will be enough to feed the global burden of disease calculations and include these risk factors, if you can call them risk factors, into the whole system. And that will enable very new ways of understanding the significance of social structure to health inequalities. So today, I think we are, at least in Norway, we are the only center of its kind, but I think globally it is rather unique because we are combining not only academic institutions, but also organizations, the UN sector, think tanks, the civil sector, into the same organizational body to reduce the global health gap. Now, all of this will be too much to read for you, so my intention is really to let you look at this presentation perhaps later on if you're interested in collecting more information. But in terms of research, we are measuring and explaining the problem of inequality with UNICEF, particularly UNICEF Innocenti, but also UNICEF New York, the WHO, particularly IARC, which is the Cancer Office, and the Global Burden of Disease Study. And we also constantly reaching out to the European Commission and governments. And in Europe, we're also working very closely with EuroHealthNet based in Brussels. And all of these are key partners. And when I'm asked, well, the same applies here. You don't have to read all of it, but please look at it again if you want to look at some of our key activities. And I will soon go on now to the case study that I promised you. So chain really, well, when people ask me why did we choose the name chain, then there is a spectacular or very interesting way of saying it, and then there is an honest way. The interesting way is to mention that chain is something, we want to break chains. We want to we'll let people break out of disadvantage, right? So we have a chain of researchers, chain of organizations, and so on. But the honest answer is really that I used what is called, I think if you use Google, and you can Google abbreviation calculator. So you write in the long name and you get a lot of nice suggestions. And I think chain was one of the top 10 suggestions. I thought, well, that's actually not such a bad idea. And then all the good ideas start appearing. So I'm now going to show you a few examples of how we work in our pillars. As I noted, we are really interested in everything, all possible ways of understanding this, from the smallest micro level to the largest. And this is an example of our capacity building, and this is what we're currently doing. We are expanding a data source which Erasmus helped to build up as well in the Euro GBD project. We are now expanding. So this is basically the largest comparative register-based study on education and cause-specific mortality which exists. And we are now expanding these data, which we have, I think, currently back to the 1970s, but we are now expanding them until 2019 or 20. And Rasmus, if you want to, reach out later on and work on this together, so please do, or other people. I mean, if anyone wants to work with us, we are chronically open to collaboration. So this would be then mortality, but we are also working on morbidity data. And I hope, and I know that some of you have also worked on the European Social Survey. I'm not sure if you're aware of this, but in the 7th round of the European Social Survey, we added a health inequality module, which we are now repeating in round 11. And this will enable us to study really the consequences of the social determinants over time, before and after the COVID situation, before or during, but perhaps even before and after. We are starting the data collection in next year, probably. So this would be a tremendously important data source for all of us who are interested in the social determinants and their effect on health. So this is the question design team. It's led now by Mirjam, and some of the other researchers might also be familiar to you. This would be a quite interesting table for those of you who are interested in using surveys like European Social Survey. And as you can see here, I'm trying to highlight that we are indeed asking healthcare questions, going from like unmet needs of healthcare to consultation of GPs, medical specialists, the reasons for not having, well, for not having their needs met. We are asking about alternative care, and we're also asking about informal care, provision of unpaid care, which is actually further down, I can see here. And we did also suggest to ask a few new items on healthcare systems, but we're not really sure if we can afford to add these variables as we have a limited space. So these are two examples of questions on healthcare, well, actually on health services and the healthcare system. Those are two different things, perhaps. And we are now testing them to really see with the interviews to see what people really understand with these words. So what do people think when they hear about health services, and what do they think? How do they interpret the healthcare system? So because we really want to know what people really think about when these questions are asked. So I'm starting to get questions. Some of the questions are extremely irrelevant, and I will come back to them. I'll try to remember them, and I actually think that I might answer even some of them during the rest of my presentation. So now I'm going slowly again to looking at the level. So where to look for explanations between the education and mortality link, or health link, if you wish. So you could start with the factors that are really close to the individuals, like age, sex, and factors that are less amenable. And going onwards to individual lifestyle factors, to networks, to living and working conditions, and then to general social, economic, and cultural conditions. And perhaps we could even add global forces, even outside of this circle again. And the whole point, of course, is that these layers interact and they impact each other. And one of the main problems I have with research doing, let's say, focusing only on lifestyles, is that lifestyles really depend on well, how we're raised. I mean, it depends on the level of education of our parents, where we lived, our neighborhood, employment conditions, housing conditions, education, work environment, and so on. So the distal causes are often the causes of the causes are often ignored in much of public health research. So I think we need to keep these layers all in the equation. And this has become even more relevant now with the COVID situation. You might have seen this figure. It is based on Claire Bambra, quite recent publication on the COVID pandemic and health inequalities. And the argument is, of course, that the COVID situation is not affecting individuals equally. It's basically increasing existing inequalities and putting more disadvantage on those who are already worse off. So this is what this figure is really showing. And based on this publication, we also made a fact sheet that you could look into later. It's even been translated into Italian. And where we are presenting the key messages from this article, that we are actually not all in it together. This is something which hits the poor populations far more. But not only the virus itself, but also the consequences of lockdowns is more severe among the lower educated, and according to other dimensions of poverty. So again, this is not something I want to go through here, but keep for your information. I think this is a quite useful fact sheet that should be used also in policy activities. And in one of the recent webinars that we had, in this one was in collaboration with UNESCO Chair and WHO Collaborating Center on Global Health and Education. We basically argue that education can work as a social vaccine against COVID-19. But have a look again at the figure that I just showed a couple of slides ago. It is possible to distinguish between different kinds of components of the welfare state. You have public health policies that are related to, let's say, the work environment, border sanitation. You have social policies that are more related to housing and education, and you also have healthcare. So all of these dimensions would together play an important role in mitigating educational inequalities in mortality and self-assessed health, for example. So this is something we have already done for public health policy and for social policy. What we did was that we applied European Social Survey, and we tried to structure the determinants according to behavioral factors, occupational factors, and living condition factors, and we tried to establish so what is really important in the explanations of health inequalities. So would behavioral inequalities matter more for health inequalities in Norway, or would it be occupation and so on? And we did that for all the countries in the European Social Survey in round 7. And what you find is that the behavioral effects would be more important in the UK, in Ireland, Spain, Sweden, Norway, and the Netherlands, while occupational factors explain inequalities to a larger extent in the countries here in the middle. And in the countries Portugal, Hungary, France, Lithuania, you find a larger effect of living conditions. So, and this has, of course, many implications and explanations. But I have to, I remember very well when I presented these results to the French government some years ago, and I was really attacked by some of the researchers there, because they meant that well, they asked me, does this mean that stopping smoking is not important? We need to focus on occupational conditions now? No, actually on living conditions. So the focus on the more proximal factors like smoking, alcohol, and all that. I think we need to see things in relation to what happened beyond. And this is one of the take-home messages. And I'm also asked, why is behavior so important in Norway? Well, the thing is that in Norway, for example, the educational distribution of occupational factors and living condition factors are already more equally distributed. So it would be, so smoking is more unequally distributed in a country like Norway as compared to other determinants. So I'm here now to the case study, and I wanted to check how much time I have for that. But I don't have. Let's see. Okay, 35. That's fine. Let's see. If I do this, I think I'll come back to the first slide again. But no, I'm back here. So the question we ask. So what is the role of the health system in explaining everything we've seen? I've done a similar study in the past where we looked at the cluster of welfare regimes. So these are not health systems, these are welfare regimes. And we wanted to see whether the prevalence and inequalities of chronic illness, if that's really, if those cluster according to welfare regimes. And we do find that they actually do cluster. And I think this was maybe one of the first studies I did in my PhD thesis. It has been tremendously a lot cited, but it's also very it has been cited because of all the problems, and that's so because I was not really able to capture the mechanism. So why is the welfare state so important? Why are welfare regimes so important in explaining the links from the welfare state setup to the outcome? And that's a fair criticism. And that's actually something we wanted to do differently now with this study. So the question we asked, to what extent does the strength of educational differences in mortality amenable to healthcare vary among European health systems? So we ask, so first of all, we wanted to find a very sensitive measure of health, which is perfectly sensitive to the health system. So in other words, which causes of death would be avoided if the healthcare system would work perfectly. So that's how we define health. So you would die only of this cause only if the healthcare system wouldn't work perfectly. So we're trying to obtain this very sensitive measure. And at the same time, we're trying to cluster health systems in a way which makes them meaningful in understanding this link. So we are applying the data I already showed you, the mortality data in 21 European populations. And this is just a list of examples of the kind of causes of death we are dealing with: leukemia, cancer of testis, cancer of cervix, tuberculosis, and so on. But how can you really decide if this is a sensitive outcome? How can you decide if these causes of death can be avoided if the health system works perfectly? Well, we did this. So we basically listed all the causes, and we asked, can we avoid this cause of death if we would tell people to behave differently? Yes or no? Could we prevent this cause if you could tell people to avoid accidents? Yes or no? And the last question: can we avoid this cause of death if the medical services would work perfectly? So if the answer would be yes on one of them, we would then define this cause of death as being amenable. And of course, in some cases, it's both. It can to some degree be avoided and to some degree not. So here we relied on the estimations of the WHO and the Global Burden of Disease Study, which says that if more than 50% of the causes can be avoided, if something is done, then it's regarded as avoidable. And I want to show you now the results. But before I do that, here is something I should spend a lot more time on, but which I can't. We can go back to it during the discussion. But we have classified, we have applied a classification of health systems, where we have, particularly, I would like to pay attention to type 2, which would be a performance and primary care-oriented system, where we have Finland, Norway, and Sweden included among the countries we have data for. And I would also like to draw the attention to type 4, which is the low supply and low performance mixed systems, where Estonia, Hungary, Poland would be the example countries. But again, I would rather refer to the publication than going through the rationale for classifying the countries in the way we have. What we see is, well, I would rather show this. This is a summary of the results, showing that there is a lot of, the confidence intervals are large, but we can definitely argue that the type 4, the low supply and low performance system has the largest inequalities. It's more difficult to say something about the others, but definitely number 4 seems to be worse off, particularly among men. But of course, with the large confidence intervals, it's really difficult to argue something very solid. The conclusions are those that I just mentioned to you. But again, this will be for information, and I hope that somewhere I have the publication. You see, I'm looking for the publication. Yeah, it's not there, so I'll have to add it in the chat, I think. So I do have some slides still that I could show you, but I would rather collect them according to the questions I get. I think I'm only like 5 minutes plus over time, which should make sufficient time for a discussion. Yeah. I already got a few questions already, Tamara. So
yes, indeed, because